54-year-old female presented with complaints of multiple joint pains and swelling for the last 3 months. So she's been having polyarthralgias, and she's a female in elderly age group. Okay, fine. Patient is experiencing joint stiffness at early morning and reduces after 2 to 3 hours. So morning stiffness, classic of inflammatory arthritis. Okay, and that too lasting for more than 1 hour. Okay, she's also experiencing fatigue from last 3 months. She's neither a diabetic nor hypertensive. She's a smoker. On examination, vitals are stable. Involved joints, PIPs, elbow, bilateral knee joints. X-ray of both the hands are shown below. It shows here wrist and metacarpophalangeal and proximal interphalangeal joints involvement. Clear? Her ESR and CRP are elevated. CRP elevated. So from this, what do we know? We are dealing with a case of rheumatoid arthritis. Because the classic joints to be involved are wrist, metacarpophalangeal joints, proximal interphalangeal joints, and they are bilaterally symmetrical. DIPs are not involved. Clear? And apart from that, we also have morning stiffness, which is again contributory. ESR and CRP are elevated. So next we order either a rheumatoid factor or anti-CCP. Correct? So here they have done a rheumatoid factor and that itself is positive. So we have a diagnosed case of rheumatoid arthritis. Identify the targets for long-term management of the above medications. So in acute management, you can try NSAIDs and you can start low dose steroids. Low dose or high dose, it depends, but steroids. However, for the long-term management, it is always methotrexate. Apart from that, we have certain things, newer drugs called biologicals. So they target what? They target the Th1 mediated immune response, which is the main pathogenesis in the development of rheumatoid arthritis. Th1 immune response. So primarily they target tumor necrosis factor alpha, interleukin 1, anti-CD20 rituximab, all of this. So these are all biologicals. So long-term management, cyclocox-1, COX-2, no, because they are NSAIDs and they are used only in the acute management. Allopurinol, no, because this is used in the treatment of gout, and here we are dealing with a case of rheumatoid arthritis. So the right option will be our biologicals, tumor necrosis factor alpha. The drugs here include adalimumab, infliximab. Other drug, etanercept. Quick take home point, we have to rule out tuberculosis before starting these biologicals, because same pathogenesis is mediated in the development of tuberculosis. So if we suppress this, TB gets reactivated. So we have to rule out tuberculosis. Thank you.